Hi, this is Dr. DeSalva. Welcome to my Psychopharmacology case conference. This was a conference that was done on February 25th, 2011. Our case involved a 30-year-old white female with a history of an eating disorder who presents with persistent anxiety, depression, and difficulty focusing. The history of present illness. This is a 30-year-old female who presents for a therapist with persistent anxiety and depression. She has a history of an eating disorder, which was anorexia nervosa, but has been asymptomatic since her late teens, but has some concerns about body image. She describes the usual symptoms of depression, including problems with lethargy, motivation, hopelessness, and insomnia, but without any suicidal ideation. She reports episodes of depression since her teens. She has chronic symptoms of anxiety manifested by worrying, muscle tension, restlessness, fidgetiness, and difficulty focusing. She denies any mood swings, drugs, or alcohol abuse, and she's currently on Adderall prescribed by her primary care physician, but her reports is that her focusing is still problematic. Her academic history is significant for having no problems in school with regards to studying, focusing, or behavioral problems. She has not been tried on any other medications in the past except for Adderall, and she has no prior psychiatric hospitalizations. Her family psychiatric history is significant for anxiety symptoms in both of her parents, but neither one of which have been treated. She denies any family history of bipolar disorder, ADD, substance abuse, drugs, or alcohol abuse. She has no active medical problems, and current medications include Adderall XR twice daily. So the question becomes the following. What is her most probable diagnosis? And what medication would you recommend to improve her depression and anxiety? Well, the best way I can visualize this, because it's a lot easier for me to be able to have something visual instead of written down, is I often think of a timeline with the x-axis representing time in years and the y-axis representing the severity of the symptoms. She definitely has depression, as graphically represented here, from her late teens to her current age of 30. She also has an eating disorder in her middle teens, which has thus so far been asymptomatic, and she has recovered very well from that. She also has a history of anxiety dating back to her early elementary school age up to her current age. And I represented this as being high because of her chronic complaints of worrying and muscle tension and difficulty focusing. Of significance is her academic history. She reported that she did well in school, from elementary school through high school, without any problems with focusing, inattention, or disruptiveness in class. She also stated that she has been on Adderall for quite a number of years now, but was prescribed to her by her primary care physician for focusing. This represents her index episode where she went to see her therapist first. And other information about her of significance is that she doesn't have any drugs or alcohol abuse. She had no history of mood swings, which may give me an indication that she may have bipolar disorder. There is a significant family history of anxiety, which, again, speaks a lot for the pervasiveness of her anxiety, not only in herself, but also in her family. So from a diagnostic perspective, my first working hypothesis is that she probably has a major depressive episode. She also has what seems to be more of a generalized anxiety disorder that again has been pervasive throughout her life. With her doing well academically in school, I want to rule out the possibility she may or may not have attention deficit disorder. Although there are some people who I've seen in practice who are very intelligent and with very minimal effort can get by and get good grades in school. So not saying that she does not have ADD, but I want to be able to rule this out later on in treatment. One way to be able to do this is, in my practice, is to be able to reduce her anxiety and her depression as much as we can and reevaluate her attention span afterwards. If her attention span is better, then I might surmise that the attentional problems were due to her anxiety and depression. If her attentional problems do not improve, then the possibility that she may have attention deficit disorder is probably likely, and that Adderall titrating up to a dose that would be helpful for her attention span would be good to continue. So therefore, my working diagnosis on axis 1 is major depression, probably recurrent, a generalized anxiety disorder, rule out attention deficit disorder, and a history of eating disorder just for historical purposes. The SSRI antidepressants are probably one of the first things that I would think about regarding treatment. You probably remember that there are only several of them that are members of this family, including Zoloft and Lexapro. Their mechanism of action is that they inhibit the serotonin reuptake pump, diagrammed here in the red arrow. This prevents the serotonin molecules to be taken back into the presynaptic neuron so that there are more of them to be able to hit the postsynaptic neurons. It is the SRI portion of the molecule that binds to the reuptake pump, and this causes the antidepressant effect with time. There are also secondary pharmacological properties of SSRIs. You remember that most SSRIs are not the same. Because of their secondary properties, more obvious during higher dosages, none of the members of this family are really exactly the same. So there are individual differences between them. Let's look at the selective serotonin reuptake inhibitors a little more closely. In terms of the amount of energy or sedation that they give, I've listed the SSRIs in order of activation and sedation. The ones on top are probably much more activating, meaning they give people more energy, and therefore you take them in the morning. This is true with Prozac and Zoloft. Towards the middle is Lexapro, which is a little bit more sedating, but definitely not as sedating as Paxil. These medications, including Lexapro and Luvox and Paxil, tend to be a little bit more sedating, and therefore they are much less likely to agitate someone who is in a very high anxiety state when they initially present to me in the office. Weight gain is an issue with all these molecules, and as you can see, the ones in the bottom, Paxil and Luvox, definitely had probably the highest weight producing side effects in this group, whereas Prozac tends to have the least. Drug-drug interactions, in other words, the interactions between these molecules and other medications, is also important. One of the things I like about Celexa and Lexapro, as well as Zoloft, is they have very little drug interactions with other molecules. Sexual dysfunction, again, is a difficult side effect with these medications. And dosing is critical when someone is being treated for depression as well as anxiety. For most of these molecules, the upper range of normal is probably going to be better to address their anxiety symptoms. But overall, my personal preference for these molecules, for these antidepressants, in terms of their efficacy, is Lexapro. It has one of the best anti-anxiety properties. It has very little problems with drug-drug interactions. It is calming and sedating, and is given at night to be able to help patients go to sleep. Well, there are other considerations regarding this case, but I welcome you to hopefully make it to the next case conference to discuss more of cases like this. And if you'd like to be included in my mailing list, please email me at info@drgisalva.com. Thank you for listening.